Well, as I understand it, this is the last lecture of the morning, so thank you for hanging in there with me. I would like to thank Dr. McInerney for the invitation to participate in this New Jersey Sports Medicine seminar. It's been a great curriculum. In the next 20 minutes, I just want to give a broad overview of 7 common locations in orthopedics where we can use ultrasound guidance to do injections. They don't have to be orthobiologic injections, but I am going to focus on that particular injectate for these applications. I'm in Texas. That's my website, texasorthobiologics.com. In 3, 2, 1. This is the handout. You can get there quickly by going to buford.info/NJ Sports 2025. And that QR code will be on every slide at a section break so that if you want to get to this website later in the presentation, you can just use the QR code as well. So I'm going to focus on the following 7 injections. We're going to talk about 4 different joints, basically the knee and the hip and the shoulder and the elbow. And this is an overview type of presentation. This is meant to stimulate thought and discussion and to make you scratch your head and say, gosh, if I'm not doing this, maybe there's something here. I do see a lot of knee patients, or I do see a lot of hip patients, or I could use ultrasound to do those injections in the office instead of sending them out. So let's jump right in and let's talk about knee injections. Obviously, the most common knee injection that we do is an intra-articular knee injection. And although I get it, I've done the residency, done the fellowship, I understand how to do landmark guided injections, but we can even be more accurate using ultrasound. So we do primarily a supralateral approach when we're using ultrasound to do an intra-articular knee injection. Why do we need ultrasound? Well, let me take a half step back. There's now been multiple studies and multiple meta-analyses looking at the accuracy of our injections with and without guidance. When we use ultrasound guidance versus blind injections just in the knee, for example, this meta-analysis showed significantly higher accuracy and significantly higher patient satisfaction. And what that relates to is less patient pain, it's a faster procedure, and the clinical outcomes do trend to be better. And so this is how we do the procedure in the office. The transducer here you can see is superior to the superior pole of the patella. The entry point is on the lateral aspect of the knee. And when we do it in this fashion, and you can see it in an expanded or magnified view here, when we bring in the needle from lateral in this fashion, we can see the needle in what's called its long axis, or we're doing the injection in the long axis. And that gives us the best view of the needle. Here you can see on the ultrasound, the needle is going to be a bright white or hyperechoic structure coming across, in this example, from right to left. The quad tendon is at the top of the screen right here. And so the bursal space is going to be right in this location here as the needle comes in. And so at this point, when you can see that well, you can guarantee 100% of the time that the needle's in the bursal space. And as you inject, you can even visualize as your injectate spreads through that space. This is an in-plane injection. It is the most common kind of bread and butter injection that orthopedic clinicians use ultrasound guidance for. What about the hip? The hip is a fantastic application where we can use MSK ultrasound to do an intra-articular injection that might otherwise require fluoroscopy or the trade-off would be a much lower success rate in truly placing something intra-articular. With ultrasound, it becomes just a couple minute procedure that you can get right literally 100% of the time if you take your time. Here's a supine patient. This is another injection where we want to be in plane. So you can see the transducer here. You can see the needle is in line with the long axis of the transducer. This gives you the ultrasound image that you see here on the right. And that yellow arrow is meant to represent the needle path. Now, just to go over the anatomy, this would be femoral neck through here. This is femoral head. Up above here, this white line, this is the acetabulum. And if there's going to be a labrum that we can see on ultrasound, it's going to be in this region right in here. So our goal in this particular approach is to take the tip of the needle and leave it away from the weight-bearing portion of the femoral head, but just a little bit superior to the neck because there's soft tissue down here that may interfere with our injection. In most humans, the joint capsule does attach down here on the femoral neck in this region here. But just to be safe and for increased accuracy, we would like to have our injection right about this location. Anywhere along this ridge line is intra-articular, but again, for a little bit better accuracy, I'd like to be a little bit superior for most of my intra-articular hip injections. And so now as we start the video, we'll look for that needle coming into the screen from high on the right. We're starting to get an idea that that needle's going to come down here. We'll give you a better image here in just a minute. Here you can see the needle coming down, and there you can see we're touching right there. That would be okay as long as you have free flow. If you wanted to improve that just a little bit, you could move it a little bit to the left. And then in some instances, we even turn on a little bit of the power Doppler just to see the injectate spread across the femoral head. Here's another example, different ultrasound. Just to highlight the needle, this is the needle path right here. As we start to inject, you can see this dark hypoechoic fluid start to track here. And so that's how we know we're in the joint. You can see the capsule expand. And so let's shift gears. Let's talk about the elbow. There's two main areas that we inject commonly, medial and lateral elbow. Essentially, technique-wise, they're very, very similar. On the lateral side of the elbow, we have the lateral tendinopathy diagnosis for which we're commonly injecting patients. And there's also the radial-collateral ligament, which is a slightly deeper structure, very close to the extensor tendon origin. Here is a graphic showing that the common extensor tendon is going to be slightly higher up on this hyperechoic line. So here you can see that the common extensor tendon originates slightly superior, if you will, on the lateral epicondyle. It's shaded in blue in this example. Deep to that, kind of occupying the lower 50% of the epicondyle, will be the radial-collateral ligament, and you can see the course of the RCL there. So functionally, when we do these injections, when the needle comes in from distal to proximal, if we're more concerned with targeting the extensor tendon, we want to be kind of at the midpoint of this epicondyle, or if anything, a little bit superior. And if we're more concerned about the radial-collateral ligament, we can make sure that we're a little bit deeper in that same anatomical location. If we were injecting the joint, that would be the joint right here. Here's the radial head, here's the joint space. So let's look at some clinical examples of these injections for what's commonly called tennis elbow. Here on the left, you can see the transducer over the lateral epicondyle. Notice the patient's supine. We'll often put a pillow between their forearm and their body to make them even more comfortable. You can see here the injection is from distal to proximal. I will often position the needle without the syringe on it because it gives me more flexibility and makes me a little bit more precise in placing the needle. So I don't like, particularly like the technique shown in this video, but you can see here how it looks after I've attached the syringe and once I know the needle is exactly where I want it to be. Now here as we look at the video, here's the epicondyle. Here's a very shallow approach with what is usually a 22 gauge needle. This is a little bit deeper injection. This may be targeting more of the radial collateral ligament, but when there's a lot of disruption, of course, the extensor origin is involved as well. You can see this hypoechoic area, and you can see that we're making one or two passes with this needle, and now we're a little bit more superior, and this would be more in the region of where the extensor tendinopathy would be located. So your ECRB and your other extensor tendons are originating a little bit higher up on the epicondyle in this region. And so that's a pretty good example of what a clinical procedure would look like. Very hard to do that and know exactly where your needle is without ultrasound guidance. There's a significant advantage in this example, in my opinion, to using ultrasound guidance. So let's talk about the shoulder next. There's three or really four locations that I wanted to cover just in a short amount of time. There's the glenohumeral joint, the long head of the biceps tendon in the biceps groove anteriorly, and then the subacromial space, which is essentially the same approach as injecting the rotator cuff tendon itself. So I like positioning patients in the lateral decubitus position. It mirrors the position I use for shoulder arthroscopy. It protects them if they have any inkling of going vasovagal. They're already in a safe position instead of being seated. And it gives you easy access all around the shoulder. So in this particular picture, what we're illustrating here is the transducer position, which is essentially right over the posterior shoulder arthroscopy portal. And this red dot is meant to demonstrate where the needle entry point is for an in-plane injection. So the needle is just at the edge of the transducer, and then we're going to inject. Here's a clinical picture on the left. You can see the transducer, you can see the needle. In our new office, we're able to have more space on both sides of the table, which is always ideal. So we can place the ultrasound image and the ultrasound machine and cart on the opposite side of the patient. Here's an example of us first injecting a little bit of lidocaine in this example into the posterior deltoid, just superficial to the infraspinatus right here. The reason we're doing that is because this patient likely had a frozen shoulder, and we're going to be injecting a fair amount of volume, maybe 60 cc's of normal saline in the office to try and give them some relief. And then once we're into the joint here, as we inject, we can watch the injectate lift off the posterior capsule in this example. And so we know that we're intra-articular. We'll look at some more pictures of that towards the end of this lecture. So let's move over to the biceps tendon sheath. This is another location where there's multiple ways to inject. And I should say that at every location, there's at least two and usually four different ways to inject, whether it's in plane, out of plane, long axis, short axis, proximal to distal, distal to proximal. And so looking at the left side, this is an example of how we could inject the long head of the biceps tendon using an in-plane injection where the transducers aligned with the long axis of the biceps tendon. And we can inject, in this example, it would be from proximal to distal, right? This is what we're injecting and targeting is right here. In this example, we would be injecting the same tendon, but now we've rotated the transducer 90 degrees. And so now we're getting a short axis view of the tendon. The tendon's going to be circular now instead of longitudinal across the screen. And our entry point for the needle is going to be just lateral. So here we're injecting from lateral to medial. Let's look at what this can look like clinically when we do this in-plane injection. It's a long axis approach. And we'll show you right over here. This is the needle path from proximal to distal. The tendon is the structure that's immediately anterior to the cortical bone. So this is the tendon. This white line is just the thickening of the fascia of the anterior deltoid, basically right over the biceps groove. And so as we inject, you'll see the needle right here. And then as we inject, you'll see the injectate, whether it's saline, steroid, PRP, bone marrow concentrate, whatever, immediately lift off the sheath and fill up the groove. And so as we inject, you can see what's happening here. See how this lifts off and hydrodissects basically proximal and distal. And that's how we know that we're in the right spot in the groove. If we were just in the muscle, there would just be a little circular expansion of the muscle as we injected. Here we're seeing the course of the injectate along the long head of the biceps tendon. So I like that position there. This is a short axis view. So here, the biceps tendon's here. This is the groove. The needle's coming in from lateral. And as we inject, we want to see that little groove get inflated, right? And so that's what we're able to demonstrate in the short axis approach. There's no real right or wrong way to do it. Sometimes the patient's anatomy dictates the best approach for you. And sometimes it's just clinician experience and which way is your favorite or which way you're the most comfortable with. Let's look at the subacromial bursa next. This is just an example of doing it seated, but remember, I like having my patients in the lateral decubitus position. In this example, we're able to locate the bursa as long as we have the patient aligned where they've brought their hand back on their hip and they've adducted their elbow, which delivers that bursal space out from under the acromion so we can target it with ultrasound. And so you can see the ultrasound is a bit more anterior. Of course, the bursal is more of an anterior structure, which is perfect. And now we're going to inject with our needle just off of the edge of the transducer. So now here's an example where we're using a slightly different approach. This is a long axis view of the rotator cuff tendon right here. This little white line is the needle, and as I run the video, you'll see the needle. And as we inject, you see that hydrodissection effect. As we inject the fluid, it tracks all the way lateral and tracks medial. And that's how we know that we've got that needle above the supraspinatus and below the deltoid. So you can obviously do this in this, what would be called a coronal approach if it was an MRI scan, or a long axis approach if you're using a more sonography-based terminology. So now we're going to look at the short axis approach. Notice the patient's positioning here. Hand is back on the hip as far as he comfortably can, elbows adducted, transducers aligned. Basically, I'm aligning the transducer from his right shoulder along the line that connects to his left hip. So that line is the line of my transducer. And then the injectate, or the needle, I should say, is right at the edge of the transducer here. And so it's going to come across from left to right on the screen. You can see it here. I want to leave the tip of the needle just below that white line. And as we do that, look what happens. See, the injectate flows all the way anterior and all the way posterior. So you want to be just below this white line. Remember, ultrasound is an imaging modality based on density changes. And the reason why this hyperechoic line exists is because the fascia underneath the deltoid is a lot denser than the supraspinatus muscle here and tendon. So when we inject here, we want to get the tip of that needle just below the white line. And if we're in the right spot, we won't meet a lot of resistance, and we'll be able to track this type of appearance as we inject. And so I want to show you something just a little more clinical. This is something we do, gosh, multiple times a week in the office nowadays. We get a lot of people referred in for rotator cuff tendinopathy, partial thickness cuff tears, and they want to try something before surgery or potentially avoid surgery altogether. And just a practical tip, our current protocol is to draw 120 cc's of blood. From that, we make 12 cc's of PRP, and then we inject around the shoulder in three locations: the glenohumeral joint, 1 or 2 cc's into the supraspinatus tendon, and 5 or 6 cc's in the subacromial space. And so this is kind of what it looks like. When we're going intratendinous, we're right there. This is that hypoechoic defect that represents partial tear in the supraspinatus tendon. So we're going to inject some, in this example, PRP here. When we back the needle out a little bit, we can just reposition and we can inject the subacromial space as well. And then the one thing that isn't shown in this particular image is we also put some into the joint, because remember, a lot of these partial tears start on the articular side, a lot, if not most. And so putting some of our biologic into the joint allows us to address the articular sided nature of these partial thickness rotator cuff tears. When we do that, we're seeing amazing results. And we were hoping to get this into publication in 2025, but it looks like it's going to be first quarter of 2026. And it's basically a pilot study in terms of the size of the study. There's 25 patients. And what we found is from those three injections done one day in the office, patients are doing fantastic. 7.5 years later on average, 22% have gone on to surgery within 7.5 years, but that means that 78% have not. And of those 78%, they're almost uniformly happy. They feel that their shoulder is allowing them to do everything they want to do, both job and recreationally. The VAS score, their pain scores, are still significantly lower at 2.7. 7 years later, we started at about 6. And so we're seeing and going to be publishing results that document this statistically significant improvement from this one day of injections in the office 7.5 years later. So I think it's a very viable option for patients in this condition, or with this condition. So thank you for your attention. Hopefully that stimulates some thought and gets more of you that aren't currently using this imaging modality at least curious enough about it to go to a course, or to when you go to some other meeting and there's ultrasound ICLs or ultrasound seminars, to at least have a look and see if this is something you can implement in your practice. I bet it is. Thanks a lot. And again, thanks for the opportunity to participate.